Hello and welcome to the topic Atrial Septal Defect in the Cardiology module. By the end of this topic, you should be able to define atrial septal defect, describe the pathophysiology of atrial septal defect, outline the classification of atrial septal defect, identify the signs and symptoms of atrial septal defect, describe the investigations done to diagnose and prognosticate atrial septal defect, and outline the principles of management of atrial septal defect. Let's get started. The International Pediatric and Congenital Cardiac Code IPCCC defines atrial septal defects as a congenital cardiac malformation in which there is a hole or pathway between the atrial chambers. ASD is a type of left to right shunt that results in an increase in pulmonary arterial blood flow. ASDs are most likely congenital heart defects to be found in adulthood. The magnitude of left to right shunt across the atrial septal defect depends on the defect size, the relative compliance of the ventricles, and the relative resistance in both the pulmonary and systemic circulation. With small ASD, left atrial pressure may exceed right atrial pressure by several millimeters of mercury, whereas with large ASDs, mean arterial pressures are nearly identical. Shunting across the interatrial septum is usually left to right and occurs predominantly in late ventricular systole and early diastole. Likely, some augmentation occurs during atrial contraction. The chronic left to right shunt results in increased pulmonary blood flow and diastolic overload of the right ventricle. The chronic significant left to right shunt can also alter the pulmonary vascular resistance, leading to pulmonary arterial hypertension, even reversal of shunt, and Eisenmenger syndrome. Based on the anatomy of the defect, they are classified as ostium secundum atrial septal defect and is the most common type of atrial septal defect and comprises about 5 to 10% of all congenital heart diseases. Located in the central portion of the atrial septum. This type of defect usually arises from an enlarged foramen ovale, inadequate growth of the septum secundum, or excessive absorption of the septum primum. Ostium primum. This defect in ostium primum is in the lower part of the atrial septum. Ostium primum defects are less common than ostium secundum defects, and this type of defect is usually associated with Down syndrome. A sinus venosus ASD is a type of atrial septal defect involving the venous inflow of either the superior vena cava or inferior vena cava. It is located at the junction of the superior vena cava and the right atrium. And finally, we have the coronary sinus defects, and these are characterized by the absence of at least a portion of the common wall that separates the coronary sinus and left atrium. Let's now look at the diagnosis of atrial septal defect. The symptoms include respiratory infections, which is common, heart failure symptoms, complications. These complications develop late in adulthood and include pulmonary hypertension and stroke. Embolism may pass from venous system to left side of the heart, causing a stroke. As for the signs, you could appreciate parasternal heave owing to an enlarged right ventricle, ejection systolic murmur from the pulmonic valve because of increased blood flow, and due to increased venous return, there is an overload of the right ventricle which prolongs the time for emptying. This explains the delayed P2 auscultated here. Echocardiogram is used to identify any defects within the heart chambers and to assess the overall function of the heart. Cardiac catheterization provides information on the pressure gradient between chambers and vessels and is also used to evaluate cardiac shunts. Let's take a look at Eisenmenger syndrome. This is described by the reversal of a left to right shunt in a congenital heart defect due to pulmonary hypertension. This occurs when an uncorrected left to right leads to modeling of the pulmonary vasculature, eventually causing obstruction to pulmonary blood and pulmonary hypertension. In this case, it can be associated with atrial septal defect. Features include original murmur that may disappear, cyanosis, clubbing, right ventricular failure, hemoptysis, and embolism. Management includes heart-lung transplantation when required. Now, the final part would be cardiac catheterizations and oxygen saturation level interpretation. Let's start with the basics. Deoxygenated blood returns to the right side of the heart via the superior vena cava and the inferior vena cava. It has an oxygen saturation level above 70%. The right atrium, right ventricle, and pulmonary artery normally has oxygen saturation levels of around 70%, and the lungs oxygenate the blood to a level of 98 to 100%. The left atrium, left ventricle, and the aorta should all therefore have oxygen saturation levels of 98 to 100%. The oxygenated blood in the left atrium mixes with the deoxygenated blood in the right atrium, resulting in intermediate levels of oxygenation from the right atrium onwards. Treatment of atrial septal defect can be divided into the small defects and the large defects. The small defects are defects less than 8 mm and are to be observed for spontaneous closure. Most defects can be treated percutaneously, while others may require surgical closure. The indications for ASD closure include significant shunt, where there is right atrial and ventricular enlargement with or without symptoms, paradoxical embolism, exercise-related cyanosis, orthodeoxia and platypnea syndrome, which is characterized by dyspnea and deoxygenation when changing from a recumbent to an upright position. Contraindications for ASD closure are severe irreversible pulmonary arterial hypertension, recent or active infection, and intracardiac thrombus. In summary, atrial septal defect is a congenital malformation where there is a pathway between the atrial chambers leading to oxygenated blood in the LA mixing with the deoxygenated blood in the RA, resulting in intermediate levels of oxygenation from the RA onwards. Ostium secundum is the commonest type of atrial septal defect. This eventually leads to pulmonary hypertension and, if left untreated, can cause Eisenmenger syndrome, which is a reversal of shunt. ASD closure is the treatment of choice. We have come to the end of this topic. Thank you.